Well, hello everybody, and a very warm welcome to the latest in our Health Chat series from the Institute of Health and Social Care Management. I am more than a little bit excited to be introducing our guest for this evening, the rather wonderful Professor Donna Hall, who amongst many other roles is chair of New Local Think Tank and Boston NHS Foundation Trust. Before we get stuck into the discussion with our very own Roy Lilly, I'd first like to introduce you to Richard Strong from Allscripts, who are our highly valued sponsors for this evening. So over to you, Richard.
Thank you, Jane. It's always great to sponsor these health chats, but tonight is an absolute pleasure for Allscripts to be supporting this one. It's always really enjoyable to listen to Donna, who amongst her many roles is chair of our client, Bolton NHS Trust, doing a fantastic job. And whenever I hear Donna speak, I always learn a lot from her insight and her wisdom, and I'm sure you will as well. So welcome to the Health Chat. Over to you, Roy.
Richard, thank you very much, and good evening, everybody. If you're watching us live, if you're watching us recorded, that means you've probably been working whilst we were broadcasting this. So wherever it is you're working, thank you for what you're doing to keep us all safe. And it's my great pleasure to say good evening to Donna. How are you, Donna? She's got to unmute. There we are.
I'm really well, thanks, Roy. How are you?
I'm fine. Have you escaped COVID, or did you? Have you had a COVID? Or?
No, I luckily, touch wood, none of me or my family have had it. So yeah. How about you?
Well, I managed to escape it because I'm so old. I've had a vaccine now, which seems to be that the news at lunchtime is very good, because it seems that the immunization now is much better than everyone thought. So it's a great blessing, I guess. So, Donna, I mean, you've got a lot of interesting things that you're doing. We'll kind of get around and talk to them all, but I'm just thought I'd start in your trust, which is, if you look at the sort of hinterland of the trust, the local economy, the sort of demographic issues. I mean, you're absolutely in the eye of the storm there, aren't you?
Yeah, I mean, particularly in the first wave, Roy, I think we had the highest infection rate in the whole country at one point.
Yeah.
Partly to do with our demographics and a lot of poverty in Bolton, but we're kind of plateaued out now. We've got an incredible team. Richard knows how incredible they are. Quite humble, they just get on with it, but are very much a kind of community district general hospital specialising in women and children's. But the most incredible staff. We've lost a lot of staff as well, through COVID. Lots of doctors, nurses, healthcare assistants, porters, cleaners, and that's when it first came home to me, when we lost our first member of staff. A wonderful woman called Lourdes, and I've never been through this kind of situation before, where you're losing staff, losing so many people, and it just sent a shockwave through me as a leader. I've never come across it, but our team are just remarkable, Roy, as the NHS has just been phenomenal, haven't they, along with our communities and local government as well.
It has, hasn't it? I mean, it's kind of turned the hierarchy of management on its head, hasn't it? I mean, whatever we say, the NHS is a top-down pyramid. There's no question about it. But what has been interesting, I think, during COVID is that the front line has become front and centre, and the trusts that have been successful have spent a lot longer listening to what has been happening in the front line, where excuse me, where leaders have gone and said, okay, I'm the leader, but what do you want? I mean, it's required a whole different approach to leadership. Have you seen that?
Definitely. We've been much more out there listening, more than we ever have done before, and responding to some of the very simple and straightforward suggestions that staff have got about how to make things better for them on the front line. People have been just incredibly imaginative in how they've adapted clinically and just generally to coping with COVID. So in our ICU, people were trying, as I think they were up and down the country, just trying new things to keep people alive in the early days of the pandemic. And you can see you know, how well that went, despite some of the, you know, I'm going to speak really honestly now, but despite some of the centralised way that things were dealt with, which I didn't agree with the way that they were done. So around testing, the stopping of community testing, and, you know, the way that test and trace was handled. But, you know, our staff were just absolutely phenomenal, as they were in Bolton Council as well.
Well, yes, I mean, Bolton played a big part, didn't it, in persuading the centre that the public health staff should have a bigger role in T&T. I think there was I mean, we excuse me, we interviewed Donna Harding, I think twice in this series, and I mean, actually, I'm a big fan. I think she had a really difficult role to play. She picked up a half-assed organisation, really, that was, you know, not properly run. She had about 40 management interfaces to try and knit together. And I think, I mean, now I think she's got it on its feet and it's working very well. But there was, I think, a reluctance to acknowledge the fact that local public health was robust enough to take this big job on.
Yeah, absolutely right. I think, you know, it's almost as if people had forgotten why they were invented, why they were created, which was exactly this situation. Local resilience forums and, you know, the whole civil contingencies arrangement was designed for a pandemic and other emergencies.
There's more to it, Donna, isn't there? I mean, if you look at how public health ended up in local government, I mean, it was in the NHS. It was, I think it's fair to say, pretty anonymous whilst it was in the NHS. Then Lansley came along and kind of shoved up the back passage of the town hall, and most of the public health people really didn't want to go there. They saw it as a kind of career stopper. They went into local government and their budgets were not ring fenced, and so they were struggling for budget, struggling for influence. And then here they are now. Everybody knows what public health is, and somehow or other it's rescued the whole. I think that I was looking at some figures the other day. Something like 80% of the tracing now is actually done by local government, which is astonishing.
Yeah, absolutely, and that should have always been, you know, it should have always been given to. Within a national policy framework, local public health teams were exactly the right people to do that fine-grained test and trace. And for some reason, I think, you know, private sector strategy consultant advised it should go to the private sector. Surprise, surprise. And it should be.
I mean, I think if you look at Public Health England, it was funded to do 10,000 tests a year, and did, you know, really esoteric testing for bizarre things that, you know, we don't get much of. It was never set up to do anything more than assay tests. It wasn't set up to authorize laboratories. It wasn't set up to do frontline testing. It was set up to receive tests from local government and use its laboratories at Hendon and Porton Down. So Public Health England wasn't set up to do that job.
No.
Local government really didn't do that job. I mean, they do food poisoning and some notifiable diseases, but it's on fairly low scale. And I think the fear was in central government that it would just be swamped.
Yeah, and I think that the decision to stop the community testing was, I don't think there was any dialogue with localities about that decision, and that was for me a fundamental flaw right at the outset, where, you know, a complete lack of recognition of what was already there, the capacity within my NHS lab, which is kind of state-of-the-art lab that just wasn't used during the testing. And, you know, we could have helped local directors of public health with their teams. I think the capacity needed to be boosted, no doubt about it, but I think 22 billion could have done a fair bit of boosting, Roy, within our localities, and could have helped us a lot without that kind of centralised. You know, you got families being contacted 20 times in a day if several people had COVID. It just wasn't, You know, people say the private sector is more cost effective. Not always, not when the strategy is wrong. So I don't blame the actual, I don't blame Serco. I actually blame the strategy. I think whoever designed that was, you know, just hadn't appreciated what was already on the ground working really well.
I don't think we're ever going to find out who it was that, as you say, you would rather elegantly say design the strategy. I think I'd say cobbled this lot together. But do you think that I mean you've got a leg in both camps, haven't you, with local government and the health service, and that's really unusual. I mean, years ago, I was in what passes for my career, I was the chairman of social services and the chairman of the district health authority. And I have to say that I during that period, I failed completely to get the two sides working together. It was just impossible. But I mean, I think, what part do you think politics plays in this, where you get a Labour council, a pretty right-wing conservative government? I mean, that creates a tension to start with, doesn't it?
Yeah, it does. But I think, you know, most social services departments within local government, whether they're run by a Labour council or a Conservative council, they want to do the best to protect most vulnerable people. And I think, you know, social care has been the kind of poor relation, hasn't it, over the years of, despite the fact it's the NHS, Department of Health, and social care is part of that same department. It doesn't seem to have the same equal status, a little bit like mental health. But, you know, we've seen that the slogan "Protect the NHS" was fundamentally flawed. Again, it should have been around protecting our vulnerable or valuable people in society. And, you know, we didn't wrap rings around care homes, and we should have done. You know, so I think some real mistakes around, you know, let's develop person-centred services across social care and the NHS, rather than having separate silos that just don't interact around the person and the family.
Yes.
You know, and that's what I've always been passionate about.
Yeah, you're right. In fact, I wrote a piece about priorities, and you know, the three things: stay at home, save the NHS, save lives. They were three priorities, and you can't have three priorities. You can only have one priority to serve the others, and the one priority was really stay at home.
Yeah.
And that's why we've had such confusing messaging. Let's talk a bit about health inequalities, because I also want you to tell us about your think tank, most of which I don't have much time for, because most think tanks don't really seem to think, as far as I can see. But so I'm happy for you to tell me I'm wrong. But let's talk about the health inequalities you've got in your area. You've got some of the worst numbers there are, aren't they?
Yeah, we've got really low levels of life expectancy and reducing. Like you've written about this before in your blogs, Roy. But they, you know, I think Marmot identified, didn't he, this time last year, just how things were going backwards instead of forwards in terms on life expectancy. So huge amount of effort in Bolton with Helen Lowy, who's the Director of Public Health, to have an integrated approach to targeting particular individuals and families with a different type of offer, you know, not just bog standard top-down public health programs. You know, a bus turns up in the middle of Bolton saying don't drink too much alcohol, and then goes the end of the day, and anyone who needed to get on the bus didn't get on it. You know, that's the kind of rubbish public health type intervention that just doesn't work. You'll know that from what you do and what you've done in the past. Just, yeah, I mean, big waste of time.
Of spuds on things and healthy diets, and most public health campaigns that I've ever seen haven't really worked that well at all. Because I think if you look at what changes things, I mean, if you look at public health, you've got crash helmets on motorbikes, seatbelts in cars, smoking in the workplace, health and safety legislation. Although we laugh about it, I mean, it is really very important. It saves people's lives. All of that, big part of the public health agenda, all of it is legislation.
Yeah.
Because legislation makes things happen. Yeah. You know, telling people not to eat too much and don't get fat doesn't work. So what legislation do you introduce for obesity? I mean, what do you do? Do you pass a law that says every chip shop has got to have a 12-inch doorway, you know, so only thin people can buy chips? I mean, what law is there? You know, do you put scales by a bus stop, and so the bus comes, you go, the guy weighs you and says, no, sorry, you weigh too much, you got to walk. I mean, what laws are there to do this. I mean, we got traffic light things on packets in supermarkets, and you know, they're too small for most people to read. I mean, none of this really works, does it?
No, I think you're right, Roy. I think the reason why I think public health works well within local government is that link to the wider economic and social determinants of health. So you've got the ability to work with colleagues in planning, in licensing, you know, for alcohol and other kind of things that councils do. But you've also got that link back to employment and healthy workplaces. But I think a lot of it is around how we relate to people. So I think very often in the NHS, we have this kind of top-down, this is what you get, and you have to do these things because they're good for you. And we don't tap into some of the problems that people face, you know, not having a job, which is going to be a lot worse when the pandemic's over and Brexit's happened and everything else. We're going to have a lot more worklessness to try and cope with. But a lot of people living in poverty have got not much hope. You know, they've got no money, and you know, the few things that they rely on are not good for them generally sometimes. So, you know, I think it's all connected. We can't just deal with the one thing that, you know.
And that's Donna, you've hit the nail on the head, haven't you? Because, you know, none of this is within the purview of the health service. Very little of it is really within the purview of local government. Most of it is in the gift of central government.
Agree.
Most of it takes longer than 5 years to change. And because the election cycle is 5 years, most people, they're not going to bother. They're going to do the minimum they can. Look at the sugar levy. I mean, the sugar levy is interesting. That's worked.
Yeah.
I don't know what the hell they've done with the levy. I don't see too many playing fields being built. But I think the actual impact that it's had on the industry has been profound, and the impact that it's had on their products has been very good for the public. So, you know, we come back to the law on all this. We keep coming back to legislation rather than persuasion.
Yeah. No, I think it's about long term. Yeah, no, I think you're right. But it's more than just NHS policy, as you say. It's about economic policy. It's about a longer term plan for the country, which is not just changed every time you get a new party in charge or a new prime minister. It's a longer term plan, and having that kind of. I mean, the King's Fund came to Wigan to look at some of the stuff we'd done there over 10 years, and the one thing that they said that was different to other places was, well, two things really: clarity of purpose of what we were there to do, working differently with citizens, having a different social contract with them, but then it was constancy of purpose. So we stuck with it over a 10-year period and didn't keep chopping and changing with different projects, sexy new shiny initiatives. You know, it was just, this is what we're going to do, and we want you to work with us as citizens.
Yeah, I mean, a lot of it is very fad management, isn't it? I can't remember the number of fads I've seen both health and local government go through. So tell us about your think tank. So what's please God, there's some new thinking going on. What are you doing?
Yeah, I mean, it's not so much a think tank, it's more of a network, Roy. So it's 70 councils, and we're getting NHS people interested. STPs and ICSs are wanting to join us now, but we're trying to subvert the relationship that the state has with citizens, which is, it was designed, as you know, in the 1940s, you know, around the Beveridge Report, very command and control, like a 1940s factory type system, which is no longer fit for purpose in the modern world. And you know, it's still operating along those principles, really, very transactional. So we're saying there should be you know, we had the state paradigm created in the 1940s, the market paradigm in the 80s, where everything was outsourced, you know, and that didn't work, did it? And then you know, really what we need is a different type of paradigm, a community paradigm, where we think differently about place, we think differently about the role of communities and citizens, and how we can work in a enabling way with them, rather than just keep doing stuff to them that doesn't work. Is hugely expensive and completely pointless, a lot of it.
If we were going to move to a more localist agenda, where, I mean, would you make local government more accountable, perhaps by local income tax?
Yeah.
Or would you continue to rely on whatever the resource allocation formula happens to be? I mean, I know that's under review, but
it is, yeah. And there's a huge review of local government going on at the moment as well, which could change some boundaries. But you know, I think local government is on its knees at the moment, Roy, in terms of the money that it's got. You know, it's been cut relentlessly over the last 10 years. You know, with most councils having their budget at least halved in terms of the grant from government. So I do think we need a different system. We need to reinvent it and think about the future. And you look at other countries, Germany, I think with a federalised model where they've got local taxation and they've got different models of governance based on a more devolved setup. And I think
they did, but that's been their failing, isn't it? In COVID, because they were federalized, they weren't able, legislatively, they weren't able to work together. It was like the United States, federal structure. I mean, it was the federal structure in Germany was set up after the war based on the US federal structure, but they just were not able to work together. The law didn't allow it.
But then, yeah, I can see that. But at the same time, they were quite good at spotting some of the early cases of COVID because they were very granular, very localized, and able to spot those early cases. So I think it's got to be a kind of policy framework that is national, but then within that, you've got a more devolved system to work differently with local businesses, NHS trusts. And
when you say working with local business, I mean, what does that mean?
I think, you know, we social value and community wealth building is something that is kind of growing in popularity. So, you know, we all, so hospitals, trusts are, you know, key anchor institutions as our councils, housing associations, and yet we just, you know, we don't think about the place that we operate within. We don't think about the value that we add to that locality. So trying to adopt that more connected approach with businesses to thinking about local purchasing, a little bit like the Preston model. I don't know if you've seen that.
I have, and of course the Jim Mackey up in Northumberland. I mean, he's set his own PPE factory up.
Yeah,
hundreds of people, and they love it. Everybody's got a job up there.
Exactly, and that's the kind of thing we need to think differently about. You know, manufacturing's dying a death.
If you do that, and I'm not saying you shouldn't do it, but I mean, if you do that, you've got a huge restructuring to think about, haven't you? I mean, it's not just about boundaries. I mean, boundaries ebb and flow all the time. The Boundary Commission is there to try and balance the numbers of, you know, as new blocks of flats are built, and, you know, try and give it some sort of equal numbers at least in the social demography. But if you look in your area, for example, you are probably, I would think, the biggest local employer.
Yes, we are, yeah.
And that includes industry as well.
Yeah.
And you are therefore the biggest influencer on the local economy. You're probably buying more stuff than anybody else is buying. I mean, more spuds, more bog rolls and what have you. I know a lot of it comes from NHS supply lines, but fundamentally you are the key financial influencer there. Local government, actually, the budgets pale into insignificance compared to what is happening in the health service. And so you end up again, we keep coming back to this, well, should health and social care, health and local government, should they merge? You know, should we end up with a Lib Dem model that I think they've dumped it now, but the idea was that they wanted local government, didn't they, to run the health service? And then you have to answer the question, well, a big chunk of social care is means tested. Health isn't. You put those two together. So how much of social care is going to be free at the point of need, and how much health service is going to be means tested? So you get immediately into a really thorny problem that no one really wants to answer.
Yeah, I mean, I think it's possible to do more of a blended approach, Roy. You know, you've got like a policy framework in terms of the NHS principles and ways of working, and a body which is, you know, a streamlined body that kind of agrees high level rules. around means testing and things like that. But then you've got a much more devolved delivery system. You know, I'm not that bothered about there being one organisation on the ground. I think you can develop a culture of working in a team for place. That's what we're trying to do in Bolton. It's what we try. It's what's going on in Wigan. It's what we're trying to do across Greater Manchester through health devolution. You know, is having that common culture of working around the citizen, around the person, not the silo organisation, which you write. You know, people used to send me your blogs when I was having a bad day with our CCG, going, help me, please. You know, and they say, look, Roy says organisational sovereignty is not the thing. And I was, yes. So I would use your words in every single meeting I had. So thank you.
I've destroyed your career quietly, but you haven't realised you'd have done so much better without me, Donna. But I'm flattered that you did, and thank you very much. If we go back to looking at local government, I mean, you are right. I mean, we had the Better Care Fund, didn't we? Where, I mean, for people who are not across this, just let me make it clear that there's health money, there's social care money, and health can't spend its money on social care and vice versa because it's against the law. So we had to have the Better Care Fund where we could lob money in and then divvy it up and spend it together. It's Section 75, and so we're able to do that. Now, of course, in the new proposed legislation, there are extensions to Section 75. The Better Care Fund has a more a better statutory footing, and if you add to that what's happened with data, where now people are just sharing data, aren't they, between health and social care? Everybody said to hell with it, we're going to do it anyway, and NHSX have said get on and do it and be sensible. If you're sharing data and you're sharing money, you don't really have to do a lot else, do you, to make the system work for the people?
I think we've got a lot of workforce remodeling to do, which is, you know, we've got, I look back at some examples that, you know, I see every serious incident that comes to our board. You know, when you unravel it, it's around not working around the person. It's not just about the data sharing. It's about, you know, everyone did very well intentioned, did their little bit of the job, but no one joined the dots. No one connected the different disciplines across the workforce and, you know, thought differently. So again, personal example, my mum, when she was discharged from Bolton Hospital, it's 5 years ago, so I wasn't there then, but 22 on one day when she was discharged, 22 different bits of the NHS, social care, pharmacy, primary care came up a path on one day. 22 different bits. Yeah. That's what we need to change.
I absolutely don't doubt that for one moment. I, you know, went through a similar situation when my mum was alive. Let's talk about workforce, because I mean it's really interesting. I mean, the reason the IHM has become the alphabet soup that it now is, which is the IHSCM. I get in terrible trouble if I don't get that right. But I've said the IHM for 30 years, and now I've got to retrain my tongue to get around all the rest of it. But now the IHM, I mean, we saw that the need for health and social care to work closer together, and we kind of want to create the environment where that can happen. We've got some exciting education programs coming up where healthcare people and social care people can learn together. Do you ever see a situation where there will be a health and social care professional working where the two roles are rolled into one?
Yeah, I think that's got to happen, Roy. Definitely, and you can see the start of it with some teams like reablements. You know, I don't know if you've worked with the reablement teams that, yeah. So, you know, that for those that don't know, they're the people who try and keep people out of hospital, put all the aids and adaptations in and support people to live their best lives. And, you know, some of the work that we did with those teams in Wigan, they were, and again, when councils were cutting them due to the cuts that they'd had, we tripled the size of our reablement team because it was a prevention team that were focused on, again, on the person, on connecting them into what was already in the local area, in the community and voluntary sector, not just statutory state-funded things that they enjoyed doing that kept them socially connected and well. And we know that it's as bad as smoking 15 cigarettes a day, isn't it? Being lonely.
There's a lot of stuff. Absolutely. I mean, yeah. I mean, I've seen it in Bristol. I saw it in Liverpool. I forget what it was now, but somebody watching will remind me. But I went somewhere other, and they had this van, a re-enablement van, and there was a community occupational therapist and the bloke driving the van, and they just turned up with aids and adaptations, because I mean, we know, don't we, for discharge it's usually a raised loose seat, a perching stool in the kitchen, and probably a couple of bars or something, or handy bars on the bed. I mean, it's not, very few people need really complex stuff.
Yeah.
So turn up with all this stuff and an electric drill and just bang, put it all in.
Yeah. But sometimes I think what doesn't happen.
I just must tell you the drama that was surrounded that, because, you know, was it a social care handy bar, or was it a social care lavatory seat, or was it a health service perching stool, because one had VAT and one didn't, and you know, they just went on and did it, and I think the finance department closed because it had a nervous breakdown.
But that's brilliant, isn't it? And that proactivity that you see in that team, you know, if we could apply that en masse to social care and the NHS, so that we're predicting who is going to need those services before they actually need them. So that, you know, because what we tend to do when we're facing funding shortfalls or workforce shortages is we raise the threshold to access our services, and we say, go away, get iller, get worse, and then come back when you are worse. And people do, you know, so by the time they get in, they're in a much more severe state. So, you know, that prevention, that focus on community, not just putting in the raised toilet seat, but having a conversation about what people are doing, and trying to connect them in with other groups in the area that they might be interested in, and supporting the community and voluntary sector.
Pharmacy, diuretics, having to go to the loo in the middle of the night. Guess what? People fall over in the dark.
Exactly. It's all connected.
It's such basic stuff. You can bang your head against the wall, can't you?
Yeah.
So what do you think, Donna, what do you think about ICSs? Are they the great white hope of this? I mean, I was talking to somebody the other day. I said I used to run an ICS, and they said, really? Where? In America? I said, no, it was here. It used to be called a district health authority.
Yeah, it did. Yeah, kind of what goes around comes around, doesn't it?
Exactly.
I think we're seeing
All we had was graph paper. We didn't have Excel spreadsheets in those days. But I mean, they do strike me as being district health authorities. And do you think they're going to end up a battle of supremacy with a trust trying to run the thing? And I mean, local government has got a place, hasn't it? But it's at the second tier of the committee. You've got like the committee that runs it, and then there's the committee of everybody involved in it. I understand that they will probably want not to have the decision making clogged down, and the consultation feeds into the decision making. I get that, but I'm not so sure that people are going to be too happy about sitting on the second tier committee.
Yeah, and I think the guidance is relying on a level of maturity that isn't there at the moment in the system. I think you've still got, as you've said in your blogs, you've still got this kind of hand-to-hand combat at some very senior levels between CCGs, trusts and councils about sovereignty. And, you know, it would be great if people could just get on with it and sort it out. But it's, in some areas, again, I see it being just a very pure NHS to NHS conversation, and local government have kind of walked away a little bit.
Tell me when you want us to come to a committee. But I suppose, I mean, the interesting thing is, I mean, I know one of your specialties is leadership, and, you know, here we are trying to lead the NHS, trying to lead social services through a pandemic, something that nobody's ever seen before. I mean, thank God they don't come along that often, but, you know, we're struggling to do that, and at the same time trying to reorganize the NHS. There would be a good argument not to do it at the moment, but there is also a good argument to strike while the iron's hot, whilst we've got a government that's prepared to accept the fact that their previous legislation's been a mess and we can get rid of Lansley. And I think Johnson, as much as I can't be bothered with him, I mean, I think he's been bold enough to say effectively get on and do it. We should take that advantage. But it is a real leadership challenge, isn't it, to try and make this work?
Yeah, I think it is.
And sorry, just to interrupt you, and it's on top of the day job. That was the point I wanted to make. I mean, you
Yeah.
are, you know, in your area, you're doing the day job, and then on top of that, you're thinking, oh, we're going to be an ICS, and how do we do all that?
Yeah, I mean, it does require that, you know, not thinking organisation, thinking person, thinking family, thinking community. And, you know, that's what has always driven us in Bolton, is that we're not getting it right. Even pre-COVID, people were falling between the cracks, and we weren't acting in a preventative way, and life expectancy was going in the wrong way. So, you know, we've got to change the way that we work. And intervening, you know, those 22 different people coming up the drive, intervening all separately, that's not sustainable. You know, that is not sustainable in any situation. So, you know, we have to remodel our workforce. We have to think differently about prevention, about how we use all of the assets in the community, schools, businesses, GP practices, and you know, try and develop a different relationship around health and well-being. It's not just, you know, this command and control structure. And you know, I don't like the word social prescribing, because it implies that the GP knows what you need and will prescribe it for you, rather than it being about you know, having a totally different relationship. We've still got that 1940s factory production line mentality that we have when you know, when the NHS was created, and the world's not like that now.
Yeah, Jane Dawes down in the West Country, she runs a very interesting, I think you know about her. She's and you go there and you know, you walk into this, I don't know what it is, coffee shop, library, reading room, sitting room, creche, and you know, in there somewhere there's a GP surgery.
Yeah,
You know, and
fantastic.
You have to look for Sam Everington's the same, up not
Yeah.
far from where I am in London. You know, he's got a garden centre, and somewhere in the middle of it all there's a GP surgery. And just around the corner from where I am, they've just the local GPs have just taken on a shop, an empty shop that just looks like, you know, a GP surgery.
Yeah, exactly. I chair a social enterprise called Possibilities, and it's for people with learning disabilities. And we have a farm, and people work on this farm. We've got, you know, pigs in the office, dogs in the office. It's but it's a completely different way of running public services, and we've got to think about you know, think more about where people are and what they want, rather than the medicalized silo driven models that we've developed within our public services, that are all separate, all dealing with the data separately, not connected, not relating to people as human beings, but relating to them as like a unit of need that we can fix, and we can't.
Yeah. So what's the upshot of this going to be, do you think, Donna? I mean, this is either the greatest opportunity the NHS and social care have had to get their act together, having learned all the things we've learned from COVID, or it's just going to be a wasted opportunity. A lot of people would have died. Some terrible things have happened. We'll pay our respects to them once a year and just go back to what we've always done.
Mm. I think, you know, Marmot said a year ago, didn't he, that we can't, because, you know, for the first time in...
Well, yeah, but I mean, Marmot said a lot of things, and a lot of Marmot's been ignored, isn't it? I mean, Marmot's got a fan club, and I'm one of them. You know, I think Marmot said some terrific things, and he's a good guy. But actually, you know, what's been the upshot of his 2 reports?
I think it's because we've not focused on the right things, have we? We've obsessed about NHS reorganisations and, you know, our individual role within that, rather than, you know, some of the fundamental messages around early years, early intervention. We've, you know, we've focused on the...
Look at Sure Start.
Yeah.
Fantastic. You know, when that was introduced, I mean, forget the politics of it. When it was introduced, it made a bang difference. Within 2 or 3 years, you could see the difference. And it got stopped. And now where are we? We got food banks and Christ knows what going on.
I know. I set up the first Sure Start centre in the country, Roy, in Salford. So, you know, I know all about that. Work with Hazel Blears on doing that. And it's,
is that right?
You know, yeah. So that...
the hospital in Salford was run by a pretty together guy as well. I can't remember his name now. Who ran
David Dalton?
David Dalton, that's right.
Yeah.
Sir David, he turned out to be.
That's right.
He was a bit of a glamour boy in the NHS. He could do no wrong.
No, that's right. That's right. David wasn't involved in the Show Start Centre. It was very much the council really setting that up. But it was, the intentions were the first 1,000 days of life. Let's get in there, and rather than focusing on organisations and governance structures and pooled budgets, let's concentrate on the first 1,000 days of life and the last 1,000 days of life, and think about how we as a system can connect in those days.
Yeah.
Because we get that wrong. Those are the points at which we get it the most wrong.
Yeah, I do like that. I'm very sorry that Sure Start's gone. So coming back to sort of where we are, we've got joint. Do you think it should be joint training, or do you think it should be tailored training? I'm not. I mean, with the IHSCM, I know that we've got a job to do to lead this part of the agenda. But I'm not clear what it would be. I mean, we've just announced that, we've got a very good relationship with the university now. We can kind of design our courses. I'm just not sure where the health stops and the public health starts and the social care starts. It's they're kind of blurred boundaries, but there's still boundaries.
Yeah, I think it's some of the things that I find missing from training are about basic values of how professionals interact with patients. I find it's very different in different settings and in different organisations, and some of that very basic setting of values and getting people to be better listeners. I don't think you can be a good leader if you're not a good listener.
Yeah.
Thinking about anthropology and ethnography and embedding that within practice, getting people to listen in a different way. And, every single serious incident I have to deal with, millions of costs down the line, it's all to do with not listening.
Yeah. Communication somewhere at the heart of it all. Yeah, if you look at let's talk about the social care workforce. A large part of the social care workforce is very low skilled. Large part English isn't their first language. A lot of them don't have real access to proper training and qualifications, and a huge number of them are employed on the minimum that their employers can get away with, in terms of the minimum wage or the working wage or what have you. I mean, and all of that, I guess, that's all toxic because we don't put enough money into these organizations to run them properly. But on one hand, you get, for example, care homes that have had a really bad time. They're mama papa shops run by well-intended people who had no chance of dealing with a pandemic because they had not a first clue how to respond to it. Other than knowing it was serious. And then at the other end, you've got these great companies that send half their profits to tax havens. I mean, it looks to me that that entire market needs better regulation, some sort of consolidation. And frankly, maybe we should even take it over and make it part of local government or health service or whatever.
Yeah.
I don't know.
I mean, it used to be.
Dare we nationalise care homes?
I wouldn't do that. No, I think it needs to be regulated but localised and brought within the remit of local government. I mean, it was all part of local government at one point, but we kind of, under the market paradigm, we outsourced it all.
Yeah. We outsourced as well, didn't we? Community health councils who were really, I thought, very effective watchdogs.
Yeah. And I think they did a good job, definitely. But the whole model of social care is based on the fact that Beveridge didn't include it, did he? And then he regretted not including it later on, and said very openly that the reason he didn't put it in was because women did it for free. Women did home care for free, and that problem has never been rectified.
And they're still doing it for free.
And they're still doing it for free. Yeah, very low value, as you said. So I think,
what about remunerating family members? I mean, they do in Germany, I think, don't they? Where family members can stop doing their job. They get paid by the state to be a carer. They go on courses. They get respite care, time off.
Yeah.
What do you
I
think?
think people need to value care, place a value on it, because it does, not always, but generally fall to women to look after people when they need support. And, you know, that is taking the pressure off the state. So I think we do need to look at packages of care for people who provide care at home. But also I think with the current
Vouchers,
setup.
Donna, do you think vouchers improve, you know, when people got their own budget? The only people I've ever seen do that have usually regretted it, and it's a huge burden on the family.
I think it's different for different families, Roy, but I think having that idea of having a personal budget, so things are not just being done to you, you have more control over your own care, I think is generally a positive thing. Have you come across the work of Social Care Futures? I don't know if you've had them on one of your health chats, but you know, Martin Rutledge and
that's right,
the team.
I met them through, actually, I was singing the praises of Birdsong. And they came to my attention as a result of Birdsong.
Yeah.
You'll be across Birdsong.
I love Birdsong. It's absolutely fantastic. And that's what we were doing in Wigan in our care home teams, was the Birdsong model. It's fantastic. Yeah, we should all be doing it.
Yeah, it's actually, there is a Birdsong team here, isn't there, that teach it. I don't know. King's one time had a big community, because King's Hospital was one of the few secondary care hospitals that also did community care. Because the history, we won't go into the history of that, but there were lots of reasons why they couldn't do it legislatively. It was quite difficult to do, but they tried the Birdsong model. They didn't get on with it very well. It does have to be a very local thing, I think.
Yeah, definitely. I think it needs to be rooted in the place, and you know, I think it could work well in a hospital on a ward. I think it could work well in a care home, and you know, integrated place-based teams as part of ICSs. Could you use it? If you're
watching this and you don't know who Birdsong is, just look it up. It's spelt peculiarly. It's BWRTZORG, Birdsong. And they've got a very interesting model of care in Holland that's worth having a look.
There's a guy called Brendan Martin as well, Roy, if you've met him.
Right here, isn't he? Yeah, Brendan's a good guy. If you're watching, hello, Brendan. Give you a shout out. Right, okay, John, we've got, it looks to me on my screen as though we got some interesting questions. Shall we spend a bit of time on questions?
Certainly, Roy. We've got Sue, who says test and trace should have been augmented around the existing local public health networks. An investment that would be sustainable, and now billions. I think Donna said 22 billion. I think she's probably right. Where on earth has all that money gone? And what could we do with it if it could be rekindled, perhaps? I guess that's Sue's question.
Somebody wrote to me the other day and said we spent 12 billion on test and trace, but NASA have only spent 4 billion putting the lander on Mars, and we know where the lander is. I thought it was priceless.
Donna, over to you. How would you?
Yeah, I mean, it's. I think I do agree 100% with Roy about Dido. I've met Dido. She's been to Bolton. You know, she's. I think under the circumstances, she's done the best she could. You know, she's had a tough time. But the strategy was written before she started. That's what I mean about the strategy being fundamentally flawed. So whichever company got the contract and however it was delivered, it would always be a disaster, really, because it's centralized, mechanized, top down, you know, your usual transactional outsourced service. And, you know, all of that infrastructure went into, you know, paying people to sit home, not taking calls all day because it was just set up wrong.
But it is working now, Donna, isn't it? I mean,
it is. It's working a lot better now.
So to say, you know, it's the private sector and it can't work.
No. I don't think it is. No, I completely. I don't think it is the Serco's fault or Dido's fault. I think whoever decided on the strategy is at fault because they didn't take account of what was there.
So you're sitting in Downing Street and somebody says, look, we got to test and trace millions of people. We say, okay, who's going to do it? Local government? No, they're busy with what they're doing. NHS, they don't have anything like that. Who's running call centres? Find me the biggest runner of a call centre. It turns out it's Serco. You say, okay, stop what you're doing. I want you to do this. And then they say, well, we got to triple our workforce. And you say, well, who does training? It's got to be online training because you know, we can't do it face to face anymore. So who's doing that? And it turns out to be whatever company it is. So suddenly you're kind of bashing all these people together, no pilots, huge urgency. What do? You just throw money at it.
Yeah, I mean, we are where we are, aren't we, Roy? But you know, I think some of the examples of, you know, that anyway, it's the whole national strategy, not just test and trace. It's airports, it's quarantine, it's lack of community testing, it's everything compounded. It's schools.
Well, everybody's trying to find one person now, aren't they? Really?
I know.
Why don't they just look at his credit card, see where he's spending money, and then go?
I know, yeah. And who could have arrived from a country and not know where he is, despite having gone through all that security? So, you know, I think, and you look at the NHS labs, you look at public health. If that 22 billion had gone into that system, we could have been in such a different place, I think.
Do you think that's true? Do you think that you could have scaled up public health to do TNT locally?
Yes.
Because they would have had to have gone and got call centres. They would have had to have hired people. They would have had to have trained people.
Yeah, but I mean, local government has call centres in place. They're already there, you know, so they could have repurposed call centres that were set up.
Yeah.
You know, and there is that we would have all worked together as a system, as you said before, 80% of test and traces is local anyway.
Yeah.
So all you're doing is, you know, you obviously set up a national framework, but you devolve that to localities to do it. And there's a centralised intelligence network nationally operating, as they have done in Wales and other parts of the UK. So, you know, I think it was us that did this in a very different way, wasn't it? Through centralising it, everything. I don't necessarily personally think private is bad all the time. You know, that's not the issue.
Local government has privatised more services than almost any other arm of government, isn't it?
Yeah.
I do remember, I go back to when the bin men were first privatised, and I remember I was the chairman of the Environmental Health Committee at the time, and had to go and see the bin men and say, you're going to be privatised. And they, I can't tell you, I can't repeat on air what they actually said. It was a nightmare. But now, of course, we've got Cleanaway, Ecovert, all these companies that we just kind of take it for granted, don't we?
All right,
yeah.
Let's. Oh, sorry, Donna. I was just about to cut across you there.
Okay, go for it, John.
I'm going to move on to, in the interest of time, I was going to cross another question. Tina, great question from Tina. She says, we've talked a lot more about death and dying this year. How can we improve the actual experience for patients and for families? That's a great question, Tina. Thank you.
What have you done in your hospital, I guess, is a good start.
Yeah, I mean, we've done loads working with our patient experience team and their families. And I was just talking to somebody this morning who lost his father about just less than maybe 8 months ago, and contacted me because we weren't responding well within the hospital. So we, you know, I think listening and learning, using all the stuff from learning from deaths, and you know, again, thinking person, not just medicalized intervention. I think there's a problem as well. We did a big board meeting around about learning from deaths, and you know, this culture amongst some clinicians about, you know, when is it time to talk about dying, you know, and speaking to people who are advocates for you know, people who've had a terrible experience of end of life. Very often that conversation doesn't happen early enough. So relatives, you know, loved ones, you don't know when to say goodbye, because people, you know, clinicians want to save everyone, so that they leave that conversation until it's too late, really. And you know, having that courage to say, so what I mean about the human to human bits of the value stuff that we don't train people a lot on, is bringing forward that conversation so that family members can have those.
It has been horrendous, though.
Awful, just awful.
Somebody told me the story of, you know, where their mum was ill, she had trouble with breathing. GP said you'd be better off in hospital with some oxygen. No, you can't go to hospital with her. No, you can't go in the ambulance. She said, I waved her off the drive, and that's the last I saw of her. Never saw her again.
Heartbreaking.
You know,
Absolutely,
and before they got the iPad thing going in the hospitals, people have had horrendous experiences of death, and there's nothing you can do. There is no way to say, well, we'll do it again, or we'll make it right next time, because each death is the experience of that person and that family. And all you can do is to say to people, I'm really sorry. We got a load of stuff horribly wrong. and we've learned from it, and I am sorry. But I
Yeah.
mean, I don't know what else you can do.
Exactly, and it's that saying sorry, and you know, try.
Yeah, you don't
Try.
want a plastic apology, do you?
No,
Speak. You
no.
want someone to say, look, be there and say, look, I am really sorry that this is
Yeah.
We didn't
Yeah.
know what else to do. I mean, at the time, we've got you know, Jules Lewis, who is works with us on bereavement, and you know, I did the bereavement book with her, and they've just worked their socks off to try and
Yeah.
improve the end of life experience for families. But it's just been awful.
Yeah.
I think we just have to put our hands up and say it's been awful. And Sue, who was it? It was Tina, wasn't it? Tina, it's been awful. And I think
it's been horrific. And I think some of the great work that Dying Matters do Roy, I don't know if you've worked with them, but they are fantastic. Set up by a guy, I can't think of his name, but his son died. And again, that conversation wasn't had. But someone's just posted in the chat, a good death is as important as a good life.
Yes, it is. And managing a good death is so difficult when you can't be near the person that you love. And that's the big thing, isn't it? John.
Yeah, I'm gonna try to roll up a few comments that we've had and a couple of questions into one, which is, how do we go about promoting the idea of localism? How do we go about empowering local level groups, be they local government or otherwise, to take control of serious situations in the future? Or will we continue just to make the same centralized mistakes if we don't?
That's a huge question.
Well, I mean, while you're gathering your thoughts, Donna, I mean, the how, I mean, when I was a local authority councillor, I did the Easing Wold Civil Defence College course on civil emergencies. And I tell you, that would not have prepared me for what we've just gone through. And so, you know, we have got to learn from this and make that an absolute part of learning for, because God knows when we're going to get another one of these. And, you know, hopefully it'll be another 200 years, but it could be 2 years, 20 years. We don't know, do we?
I think that's part of the point that several people are making, is that, you know, we'd be idiots to assume this is the last, you know, crisis that we're going to have. So how do we make sure that in future we do cede authority to local level organizations?
I think we have to fund local government and make contingency planning a legal requirement, so that they can actually open the doors and there's PPE and they can pull a plan off the shelf. So we're not all running to catch up. And you will know, Donna, local government does a lot of contingency planning for civil emergencies, but nothing like this.
No, nothing like this. And I think learning from the lessons from the 2016 Cygnus exercise that was meant, and I remember being part of that, identified we didn't have enough PPE, and identified we didn't have enough people on the ground, and identified issues around testing and vaccines. You know, we did nothing with it. So it's got to be followed up with action. But I think that the things that have come into sharp focus have been the power of local communities and local connection during this pandemic, and how important it is that we tap into that resource. And I don't think the NHS or local government have done that well in the past. So I think
it's the Civil Amenities Act or something, isn't it, that goes back?
Civil Contingencies Act, yes.
Civil Contingencies Act, that's right, which goes back to, I don't know, in the 50s or something, which is, you know, that desperately needs overhaul, I think.
It does, definitely. And but you know, the bones of that were the right things to do. I just don't think they've been resourced properly, and I think they were superseded by new legislation, the Coronavirus Act, back in March last year, which kind of all the civil contingency and civil local resilience fora, that they were overtaken by this new piece of legislation. Then obviously Test and Trace was set up. But you know, I think going back to that local prioritization, and kind of, I think one of the things that people have found refreshing about the way the NHS has coped with the pandemic is some of that top-down obsession with the 4-hour wait, obsession with, you know, delayed transfer, the outputs that we used to be, you know, have sleepless nights over. We've just worked together in places with communities to make things better and to get through to the next day.
Yeah. John, I think we should let Richard, because Richard, you've crossed paths with Donna, haven't you, in a previous life?
Well, in the current life, yeah.
Yeah.
Yeah, Bolton is one of our clients, and, you know, as Donna said, a fantastic group of people throughout the
Do they pay
organisation.
their invoices on time, Richard?
Absolutely. But, you know, a wonderful organisation, Bolton, and as you said, you know, coping with major problems. I do wonder, Donna, very quickly, you know, you talked about workforce remodelling and whatever, and clearly the challenges of so much, you know, difficult death and whatever. How are the trust thinking, and how do you then sort of roll that into workforce remodelling about the, you know, the burnout that's coming of the workforce, the mental health challenges, etc. How are you going to cope with that once we're out of this pandemic at some point?
I think, first of all, making it okay to not be okay. I think that's a bit of a cliche, but you know, that there is this kind of heroic leadership culture in some parts of the NHS, isn't there, where it's kind of drummed into you that the patient is first and you come second. I think people have seen so much death, Richard, you know, in the last year. It's been horrific. No one would have imagined that we would have 123,000 people lose their lives in the last 12 months. You know, we thought that we would be, you know, I remember that speech that Matt Hancock gave that said, because we've got the NHS, where it's not like other places, we don't see this as being a significant risk to our population. And, you know, it has been horrific, a tragedy on a huge, unprecedented scale. So our staff have seen a lot of death. We've had junior, you know, newly trained nurses and doctors coming in, and imagine the first year they've had. You know, you don't see that level of death in a lifetime practicing medicine, and, you know, they've had that all at once thrown at them, and plus what Roy's just said about not having families there to be with the loved ones when they're dying is, you know, it's so traumatizing for the staff. We've had staff that have lost their lives, you know, really loved colleagues that have been with the trust for years. So it's that build up, plus they've not been able to see their families. Many have been living in hotels, you know, they've not had that contact with the family. So huge amount of pressure and stress, making sure people take holidays. We've got the Shiny Mind app, which you might have put in for us, actually, I don't know. But the electronic patient record stuff that, again, Allscripts did with us, gosh, if we hadn't have had that, I don't know where we'd be now, to be honest.
I've lost my performance bonus because it's 1 minute, so it's 2 minutes past 6, and we're supposed to finish at 6. But it's been so interesting to talk to you. I mean, you know, so much has gone wrong. We've spent money and wasted it like water down the drain, and a lot of things, but a lot of things have gone right. And I know where you are in your hospital, you've done a huge amount that's right. We know that because you've shared stuff with the Academy of Fabulous stuff. And the fact that you've got this experience in local government and in health, that gives me huge optimism for the future and what you're going to achieve. You've achieved an enormous amount already, but I think that's only the beginning, Donna. I think you're going to become an example to us all in getting health and social care working together. I've enormously enjoyed talking to you. I'm sorry that we've run out of time. And thank you so much. It's been really invigorating and stimulating to talk with you.
And thank you for your inspiration, daily inspiration, Roy.
Well, thank you. It's my pleasure to be able to write what I do. So I consider myself really very lucky. So let's hand back to John.
Thank you, Roy, and thank you, Donna. I echo Roy's thanks to you. You've been a smashing guest for us. I'd also like to thank Highland Marketing and Allscripts, of course, for their continued support of these Health Chat events, which will go on. We are planning 2 or 3 every month from here on in, for as long as it takes, you know. We're determined to provide great value to our Institute of Health and Social Care members, and we're planning all sorts of new initiatives to reinforce that. But for now, if you're in the audience and you'd like to stay on and just chat to Donna informally, do please remain on, but we're going to end the recording of the session now. Thank you very much. Good night.